Thank you, Dr. Abraham. Good evening, distinguished colleagues, my respected teachers. Our chief host of today's session, Acting Chief Medical Director of Usman Danford University Teaching Hospital, Sokoto, Professor Muhammad Sani. Our guest of honor, Medical Director and CEO of Federal Neuropsychiatric Hospital, Kwari, Sokoto, Dr. Abubakar Suleiman Baguda. Special guest of honor, ably represented by the Treasurer of NAD, ESCOs and members of ARD Sokoto, invited guests, ladies and gentlemen, you're all welcome to today's session. It is a special honor for me to chair this session today for two reasons. Firstly, the choice of topic, which is not only timely, but very important looking at this crucial moment, looking at the rate of brain drain due to JAPA syndrome, job dissatisfaction, and other factors that contribute to heavy workloads on the health care workers in Nigeria. So, secondly, the honor and privilege to introduce my teacher, my trainer, our mentor, Professor MIFTAHU YUNUSA, a consultant psychiatrist, who has spent decades teaching, treating, and advocating for mental health, not just for patients, but for the health workforce that care for them. Who is better to speak to us about burnout than he who has studied the human mind and also mentored many of us through the toughest years of training? Prof. Sir, on behalf of ARG and all of us here, we welcome you and look forward to learning from you. At this point, I want to urge our distinguished colleagues to give our full attention to our keynote speaker as he takes us through burnout in healthcare, understanding mental health crisis, and pathways to recovery. Prof. Sir, you're welcome.
Thank you so much, my MD. I'm grateful and honored to be associated with you, and not to overstay, I can say that your presence in Sokoto State and Kwari in particular has contributed significantly, particularly in brotherhood among the doctors and psychiatrists in particular. And I feel so honored that I could be privileged to present this paper. Please, can I confirm that my voice is audible enough?
No, sir.
It's not audible. It's not audible enough.
The tones are much, it's a bit low.
Okay. Okay. I said I appreciated the MD of Psychiatry Hospital Kwari for honoring the invitation and for bringing together psychiatrists in Sokoto State, and has extended hands of fellowship and brotherhood to psychiatrists across the states. And I feel deeply honored to be associated with you, sir. So can I confirm that my voice is okay enough?
Yes, sir.
Oh, thank you so much, sir. So that takes me to my presentation, which I hope to share my slides in a few minutes. Thank you. So please, can I confirm that my slide is being seen?
Yes, sir.
Okay, thank you so
Yes,
much.
sir.
Well, like my MD has said, I'm going to speak. I'm sorry, I'm in the midst of people, my colleagues, so I wouldn't want to shout too much so that I don't distract their attention. I apologize for that. And generally, I have fairly low volume, low voice, so please kindly bear with me. I'm going to try to make sure that while I don't want to distract their attention, at the same time, I'm going to try to be as audible as possible. Well, my name is YUNUSA, and I'd like to be addressed as a student of Professor Ayodele Obende, who trained me and spent the best part of his life training resident doctors and managing his patients. Myself, my department of psychiatry, and I believe that Federal Psychiatric Hospital Quarry have a lot of gratitude to him for in terms of residing psychiatry in Sokoto State, as well as across the north. He was with us since 1996 to about 2020, and we lost him in 2022. His blessed memory. Yeah, so what we're trying to talk about is burnout syndrome and how it relates to healthcare system. And I want to suggest that at the end of this discussion, we will have an idea about what is burnout syndrome, healthcare system, categories of sufferers, and how do we manage burnout syndrome. Previously, burnout syndrome, or synonymously has been described as emotional overload syndrome, and otherwise called work fatigue syndrome. The issue of the terminology, sometimes they call it burnt out syndrome, sometimes they call it burnout syndrome. So each of them are okay. So we can define burnout syndrome as a reaction that individuals may have to face because of work demands and pressure, which do not fit into his knowledge and abilities, and test his ability to cope with the situation. Frodenberger was the one that described this condition, and he described as burnt or consumed of. And he described this among the volunteer health personnel in New York who were working with people with drug use problem. And what he observed were that these individuals, they have anhedonia, that is lack of enjoyment, lack of interest in work, fatigue, and depression. Later also described some risk factors associated with this condition. And this includes not having a fixed schedule, working a high number of hours, a tense, committed, and demanding social context, and a suboptimal wage. Syndrome can affect anyone who is working, and is commonly described among health workers who meet two specific qualities. Number one, excessively long, strenuous hours, and two, direct contact with people. While attempting at explaining how it developed, different types of models have been described, but the one we go to today is what we call psychosocial model of burnout syndrome. And Cavajal and Emocelia describe 4 stages. And these are, number one, the stage of idealism and enthusiasm, in which the individual has a high level of energy and unrealistic expectations from the organization. The problem arises when the expectations are not met, and the individual begins to get frustrated. At the stage 2, It's characterized by decrease in activities performed. So somebody with high enthusiasm before now have decreased activities, and at stage 3 is called stage of apathy. It becomes a target for burnout syndrome. And then lastly, we have stage of distancing, in which individuals feel empty and that proceeds to emotional distancing since the profession becomes devalued. So these are the 4 stages that individuals experience. That is the stage of idealism and enthusiasm, the stage of stagnation, stage of apathy, and lastly, stage of distancing. Other theories that have been propounded included psychocognitive theory and alexithymia. So this also tries to explain how this pathology come about. How do we diagnose burnout syndrome? We use an instrument called Maslach burnout inventory, which comprises of 3 components, which include emotional exhaustion, depersonalization, and personal accomplishments. Each of these components has different items. Emotional exhaustion has 9 items, depersonalization has 5 items, and personal accomplishment has 8 items. Now, with regard to clinical manifestations, subjects that suffer from burnout syndrome experience some clinical conditions, which may be symptoms, and some of them may be signs. Symptoms because it's subjective, this the patient's experiences, while signs are things that the doctor can elicit, particularly under mental state examination. And therefore, for burnout syndrome to be diagnosed and managed properly, psychiatrists must be involved. Under the clinical manifestations, we have what's called cognitive manifestation, which comprises of memory problems, suicidal ideation, ideas of guilt or self-immolation, and low self-esteem. For us as medical doctor, when we have patients like this, we know that with these symptoms, this differential will be depressive disorder. And that calls for attention that when you have a patient that has depressive disorder or depressive symptoms, it's important to rule out burnout syndrome, particularly if the person is in working class group. Then they also experience emotional components, which comprise of depression, frustration, irritability, anxiety, feeling worn out, boredom, disappointment, and difficulty controlling and expressing emotions. All this, incidentally, can be found among those with depressive disorder. Of course, somebody can have double disease condition where he has burnout syndrome as well as depressive disorder. So it requires that one has to determine which of them am I dealing with, or is it a combination of the 2? They can also experience somatic or physical experiences. This includes tension, headache, gastrointestinal problems, fatigue, myalgia, insomnia, and non-specific pain, increased upper respiratory tract infection and gastroenteritis, low back pain, high blood pressure, decrease in total number of lymphocytes, particularly T cells and natural killers. Of course, we can understand why this should be so, how it's manifested in the physical components of the body, because with stress, cortisol is produced, which is called anti-stress hormone. And with cortisol production, immune system is become weaker, and then you have an impact on the immune system or immune cells. Then you can have behavioral problems, which include difficulty relaxing, cynicism, work absenteeism, decreased productivity, decreased interest in work, increased use of alcohol, and involvement in high-risk activities. Sometimes there are suspicious behaviors, inflexibility, and rigidity. These components can be misdiagnosed as personality disorders. And that is why pre-morbid personality assessment is very important to be sure that this is not a new thing and not a previous personality behavior. Then you can have interpersonal problems, which include isolation, and then there can be superficiality in contact with others. The manifestation may be at two stages or two different areas, which include at the individual level and organization level. For the purpose of this study or presentation, we are going to pay more attention to individual level. At individual level, there are three main manifestations that must be addressed, and this include emotional exhaustion, depersonalization, and lack of personal fulfillment. Under emotional exhaustion, this manifestation is the easiest of the three to treat. So it is important for us that when we identify such problem, we should know that we have other two components that may be a bit challenging, but for emotional exhaustion, it may be a bit easier for us to treat. And that involves the good resting and apparently taking some days off, and then job control, meaning that we assess the work environment of the individual and then intervene as the case may be. Under depersonalization, we require stress management training and increased work help. If there are two individuals that are working, suggesting that the personnel are not enough, then we increase it, and that can help towards. And then there can be lack of personal fulfillment. This is frequently managed using cognitive behavioral therapy. Cognitive, which is about the thought component of our person, and then behavior, the behavioral components. So we manage the thinking component and how the person behave or react to a situation. We must remember, particularly for those of us who are the administrative side, including my MD, that those who suffer from burnout syndrome, they tend to make riskier decisions and wrong judgments. So the outcome, clinical outcome, may become negatively impacted. So it may be necessary as an administrator to ensure that our staff are not, they do not experience these symptoms or syndromes, because in clinical settings, if somebody has risky decisions and wrong judgments, it may impact negatively on the health outcome of the seekers, the sick individual. Now, studies have shown that the most frequently studied are the doctors, the nurses, teachers, athletes, police officers, caregivers, medical students. Please don't forget that any individual that are involved in work can be affected, but those who are most frequently studied are this group of people, and in particular, doctors and nurses. Now, when we talk about burnout syndrome among health workforce, we must know the following: that the right of health workforce, it is the right of health workforce to work in a safe, secure, and reassuring environment. So we should ask ourselves, the environment where we work, particularly the administrators, is it safe? Is it secure? Is it reassuring? Unfortunately for us, we cannot guarantee this in Nigeria. We had experience of a medical doctor who was assaulted in a health institution in this country of recent. So can we say that that environment is safe? Is it secure? And is it reassured? And work within specified time frame. Is it possible in Nigeria to work within specified time frame as a medical doctor and to receive a commensurate remuneration of work done? This has to do with Hippocratic Oath, which says that if I keep this oath, may all good things of life be mine. And if I refuse to keep this oath, then the opposite happens to me. The question is that while doctors and the nurses are putting on up their best as possible, their remuneration is justified. So, and with this circumstance, the doctors, the nurses, the health workers become vulnerable to burnout syndrome. But who cares? Do we really care? I'm not sure about that. So, in the hospital setting, there are some basic things that administrators, doctors must be cognizant of, that there are basic needs in the hospital setup that cannot be, that there's no controversy about it. But this includes what you take for granted: surplus water. It's not uncommon in hospital settings that there's no water to wash hands. This is a problem. So surplus water, well-lit environment, antimicrobial and cleaning agents, and friendly office environments with appropriate temperature. Current situation in Nigeria, not particularly in Sokoto, across the country, inadequate water supply, poorly lit work environments, and rarely available antimicrobial and cleansing agents. At times, there's no water. Sometimes there's water is only available, no disinfectant or soapy water. Some water available, but only Omo available, and only rarely do you find water surplus plus disinfectants. This is an aberration, and this actually increases the risk of vulnerability of doctors, nurses suffering from this condition. What's the current situation? Few medical doctors, no thanks to DAPA syndrome, few nurses, and poorly paid workforce. And what are the consequences of this? We have overworked doctors, overworked nurses, increased risk to errors, increased risk to falling ill, being less safety conscious, increased risk to infectious diseases, increased morbidity, and increased mortality. Example, a 44-year-old woman without a stable partner, a nurse, who has at least 19 years of seniority at work with more than 21 patients in charge and in a working day, greater than 36 hours a week. This kind of person is likely to suffer from burnout syndrome. But do we care? Do the system care? Now, in the healthcare settings, we have the personnel, we have the infrastructure. Among the personnel, of course, patient is the core or the center of care. But we have medical doctors, we have nurses, pharmacists, dietitians, nutritionists, physiotherapists, radiographers, laboratory scientists, ward servants, ward attendants, administrative staff. And among medical doctors, we have categories, different categories with different increased possibility of risk for burnout syndrome. House officers, senior house officers, registrar 2, registrar 1, senior registrar 2, senior registrar 1, consultants, and medical officers. Those who are highly vulnerable to burnout syndrome, if you really care and look for it, these are the house officers, the senior house officers, and registrar 2. And who are likely to have lower vulnerability will include consultants and medical officers. Somebody asked me why medical officers? Because medical officers, they have limited role to play, services in terms of what exactly to do, when to do what, and how to do it. So this is not the same with those who are in training, who have to get up at a time that they cannot choose, and who have to extend time even beyond human capacity. So that's why consultant and medical officers fall. A medical officer can decide to change place, to change the center of work easily. Whereas those in training, it may not be easy to do that. So they have some freedom, just like consultants have to start to extend some freedom. But so therefore, the vulnerability to burnout syndrome is a bit less compared to the previous categories. Nurses, under nurses, we have nursing officer 2, nursing officer 1, senior nursing officer, principal nursing officer, assistant chief nursing officer, assistant director of nursing officer, and deputy director of nursing officer. So DDNS. Among them, those who are highly vulnerable will include the nursing officer 2 and nursing officer 1. And those who are less vulnerable or no have vulnerability will include assistant director of nursing officer and deputy director of nursing officer. Now, essentially, when we talk about workforce in the hospital settings, we frequently pay attention to medical doctors, nurses. We rarely study what happened among the ward servants, what happened among the ward attendants. We have forgotten that ward servants and ward attendants, their activity determines the morbidity and mortality among doctors. If a ward servant was asked to go and clean the table or clean the couch, and he thought that that's an opportunity for him or her to take some disinfectant home. So instead of using a cup full of cup full of disinfectant, use half or 1/3. It has increased the risk of doctors, nurses, but we don't care about them. And these are very important part of our workforce. So what servants we have not really do have. I searched, I didn't find any study that suggests to look for burnout syndrome among what servants and what attendants. I didn't find anyone. Therefore, in Nigeria as of today, first of all, having burnout syndrome should be exceptional and not a rule, because in a caring environment, in an environment that cares for its services, for its workforce, having burnout syndrome should be exceptional and not a rule. But incidentally, in Nigeria, having no burnout syndrome is exceptional and not a rule. People are overworked. They are working in a very difficult environment with poor remuneration. In spite of the poor remuneration, they have to pay NME levies, MDCAN levy, NAMDA, ARD, PAYE, faculty due, college due, MDCN, graduation, research, publication, conference attendance within and outside Nigeria. They have to pay school fees for their homes, for their children, feeding, house rents, water, electricity, salary, fasting, security. All these have to come from that poorly remunerated fees. So therefore, these individuals, doctors, nurses, it's not surprising that they are likely, even though we don't care to study or to intervene. Before we now talk about examinations for the resident doctors, primary exam, part 1 and part 2, with all its attendant financial strain on the colleagues. Now, what has been the consequence of all this? Consequence of poor remuneration among health workers, health workforce. We now have doctors, medical doctors selling palm oil. And it's not feeling ashamed of doing that. I'm sorry to say that. Well, selling yam, selling chickens, selling gari, selling clothes. And we have ward attendants that impersonate that is a medical doctor outside the hospital settings. And this has impact on who enrolled to medical school. I take the last JAMB, for example. The 10 candidates that got the best results, the first candidate was a female, and that girl got about 392 out of 400. She was the topmost of the 10. The other one got in the range between 392 to 385, 10 of them. Only the first person said wanted to study medicine. Only the first person. The other 9, either ICT, IT, computer science, and whereas we all know that previously, the best of the best are enrolled in medical school. And what is the consequence? We have to lower the standard. Because when we have mass failure, then the student will ask questions, why should they fail? We are forgetting that. And if people say, why do, okay, if it is true that it is like this, why do we have high marks that we still have to put there? Because the number of people that apply into medicine are much. And therefore, they have to use cutoff mark that will reduce the number. Otherwise, the quality of students enrolling continue to drain, lowered every time. How do we treat this condition, burnout syndrome? We have, like I said before, it's an interaction between individual and the workplace. That's the most important thing. You cannot have burnout syndrome in a system where there's no work. So it's an interaction between, and the consequence of that interaction is what results into this psychiatric condition, psychiatric mobility called burnout syndrome. Therefore, if you want to manage, it's straightforward. Manage the person and manage the workplace. It's as simple as that. But what we have found out is that among the treatment available or possible treatments, the one that's most effective
Um, the screen is not showing, and sir, your voice is not audible.
It seemed, it seemed he has been locked out for Dr. Abraham. He's not even on the call.
It's like Prof is having network challenge. Let's give him some minute, please.
We are very sorry for the network glitch. Please let's exercise some patience while we try to get back online. Thank you.
Prof. UNUSA couldn't log in back, isn't it?
Sorry, he's trying to reconnect. There is problem of my network from his side. We are sorry, please.
Welcome back, sir.
I'm sorry that so can you see my slides, please?
Yes, sir.
Yes, my slides, sir. Thank you, sir. So, like I was saying, at the point of treatment, we have to focus attention on individuals and as well as the organization. I said before that the most effective treatment modality is CBT, or cognitive behavioral therapy. And how do we do that? We give workload that is fairly enough in terms of duration and type of work given to individual. It's in our work environment. It's not uncommon that a medical doctor will do the work of consultant will do the work of health officer, registrar, registrar. Health officer will do the work of ward attendants and nurses, and all sorts of crisscross approach to our activities, and which has to be corrected. We have to do the work of an electrician, the work of plumbers. So all these have impact, negative impact on productivity, and consequently overall satisfaction to job. Other aspect is about work-life balance. As medical doctors in particular, sometimes I ask myself, why did I come to medicine? After I've been a nurse, I have 5 days, 5 nights, 5 days off. And but I've chosen to be a medical doctor, and but the challenge is there. So as a doctor and as administrator, there's what's called work-life balance. There should be a balance between work environment or work duration as well as life outside hospital environment. There must be a balance. We must not spend all our time or the most useful part of our time in hospital environment, because doing extra work activities, for example, at home, families, friends, neighbors, this helps the individual to revitalize himself. I've talked about it before. Cognitive behavioral therapy is the best approach to treatment of. This is actually a form of psychological treatment. We call it psychotherapy, and it's a structured method of using psychological treatment to manage and to manage the thoughts of individuals as well as the behavior of individuals. It has an approach. It is specific, and the goal is very clear. That's in CBT. There are controversies and other approaches that have been used in the past, including mindfulness, which is meditation technique that consists of observing reality in the present moment without the intention of judging and with full openness and acceptance. And this has been described to be useful in medical students. For organizational, a study has shown that we can use meetings in the workplace and multiple approaches to based on maladjustment and general learning based on problems, meetings of rehabilitation with the supervisor and traditional rehabilitation. Light therapy has also been reported to be useful, and then cognitive coping training. So all these have been reported, but there are a lot of controversy around it. The only well-established approach is CBT, and then environmental manipulation, which include duration of work, and then the job description should be strictly based on job skills. So in summary, I've tried to describe burnout syndrome, how it relates to health workforce, and in particular in Nigeria, and why Nigerian health workforce are vulnerable to this syndrome, and what are the consequences in terms of errors, in terms of judgment, and risky taking. So thank you so much. I'm grateful. That ends my presentation. Hello? I hope they heard me.
Thank you very much for the insightful and educative lecture. While the lecture was ongoing, we had the honor of having Dr. Ibrahim Digi, who's the past ARD president, who is social past non-purpose leader, and the current leader of our zone. Thank you very much for being in our midst. During the course of the lecture also, the immediate past MDCAN president, Dr. Nuruddin Altin Aliu, you are highly welcome, sir. And also, during the
Please,
course
can I
of the
confirm
presentation,
that I've completed my presentation?
yes, sir, you've completed your presentation. The next thing is question and answer, sir.
Oh, thank you so much, sir.
Yes, sir.
It's quite a little inaudible here. So if I didn't hear you properly, you can send as a text message.
Okay, sir.
Okay, sir.
Thank you very much, Prof. Sir. That was a master class, not just a lecture. Prof reminded us that burnt out is a syndrome, not a character flaw. He also reminded us that it's affect virtually our cognition, our behavior, emotions, bodily complaints can also arise from burnout syndrome. And also reminded us that stethoscope cannot listen if the doctor's own heart is tired. And he gave us practical steps that can be approached, including light therapy, the cognitive behavioral therapies, to be able to address burnout syndrome. At this point, can we entertain questions, contributions, and comments from Prof lectures? Thank you.
Kindly signify by raising hands if you have any question. Additionally, you can also write in the chat box.
Hello, Prof. Sir.
Yes, sir.
Uh, I Yes, sir. I want to ask, sir, from your experience, sir. Sir, what are the early red flags that can be seen or warning signs that suggest burnout from your years of experience training resident, teaching students, and also interacting with other health workers in the hospital, sir? Because
Well, thank you so much.
Mr. Chairman, sir, there is a question in the
Okay,
chat box.
can you hear me now? Can you hear me now? Hello? Can you hear me? Okay, listen. Can you hear me?
Yes,
Yes,
sir, we
sir.
can hear you, sir.
Okay. Thank you so much for the question. Incidentally, I can say that identifying and making diagnosis of this condition is going to be very difficult. Difficult because if you look at the barrage of symptoms present in these patients or individuals, they are likely to end up seeing family physician. That is what are likely to happen, based both in terms of the psychological problem and as well as the somatic problems. Somebody come and say, I'm having problem with my abdomen, I have problem sleeping. These are likely to come. It's not likely that we end up with psychiatrists. However, in the presence of if you have a high index of suspicion, then it is easier to identify this condition. How common is this condition? It is, I've not done a study among these individuals or among the health workers, but it is, I can predict that if we find time to look for it, they are fairly common back, and they almost predict that. That was why I said that in Nigeria, health work environments, the rule is to have burnout syndrome, not otherwise. So people take it for granted when they go through these difficulties, and instead of people searching what caused this, then the likely is that people will get query and sometimes they lost their job. So what I'm trying to say is that it's fairly common, but just that it's lost in the maze. Thank you so much.
Sir, in the chat box, there are two questions. The first
Yes, sir.
is thank you for the presentation, sir. It is really insightful and educative. Please, what are the strategies for preventing burnout, especially in our settings that manpower has always been an issue?
So, sir, can I assume that it's my MD that's talking?
Yes, sir.
Oh, thank you. That's good. So I can address you properly. Leadership, it's a big task. And to whom much is given, much is expected. Leaders have a lot of role to play. And if they refuse to play that role, sadly, psychiatrists cannot fulfill that role, because it has a lot to do with relationship with work environments. The leaders can decide to make the environment more friendly and more comforting, and that will reduce the prevalence of this condition. With regards to the staff, I'm sorry to say this, it's beyond them to decide whether they're going to have it or not. We have cases of people who are in psychiatry, who are in residency training for 4 years, 6 years, 7 years, 9 years. And people should ask questions, why is it so? It's not unlikely that such individuals have gone through burnout syndrome or they are going through it already. But what usually happens to such resident doctors? The system sent them away without considering that they contributed to that circumstances. And psychiatrists, what can psychiatrists do? Because don't forget that psychiatrists still have a lot of stigma around it. So for a doctor who feels exhausted emotionally, physically, to now think that it's psychiatry and he has to go and see psychiatrists, it's a problem, it's challenging. But if the administrators, just like we say that, okay, before you are appointed or employed, you go through some medical investigations, and then from time to time, you also do that. If the administrators who cares about his staff or workforce, from time to time, maybe every 6 months, or every 12 months, do this, then it's possible to get them and to support them and become more productive to the society or to the community. Thank you so much, sir.
Thank you, sir, for the response. The second question is, good evening, sir. Please, sir, if you can elaborate more on the treatment modalities, the light therapy, and others. Thank you.
Incidentally, I chose not to deal too much on it because this is a highly specialized treatment that is beyond the scope of this interaction. But like I tried to mention, the basics of CBT, which has been described as the most effective form of treatment for this condition, it has to do with cognition components, which are our thinking, our thoughts, and then our behavior components, which is how we react to those thoughts. And then we try to manipulate them to achieve a particular objective. Even if we do that, while it is effective, the difficult environment or the strenuous environment, if it's not corrected through environmental manipulation, the chance is that it can have a repeat. Thank you so much.
Thank you. Thank you very much, sir, for the responses. Those are the questions that we have so far. The next item on the agenda is comments by and other invited guests. Before we delve into those comments, let me take a moment to acknowledge the presence of one of the representatives of the NAT presidents, in person of the treasurer of NAD, Dr. Kabiru Salis Lawal. You are highly welcome. Let me also take a moment to welcome Dr. Uzair Abdullahi, immediate past chief editor of NAD. You are welcome, sir. Also, during the presentation, the Director of Medical Services joined the presentation. You are highly welcome, sir. Just like I mentioned, the next item on the agenda is comments by our acting CMD, Prof. Usman Muhammad Sani.
Good evening, all. I want to first of all thank the ARD for inviting me and giving me opportunity to talk, and also want to appreciate all the effort they have been making, the whole residents, and also for choosing this very important topic for discussion. The issue of burnout is real. It's a big problem, and even we at management were really quite aware of the problem. The biggest problem is the manpower shortage, the increased workload, and it's really we find ourselves in a very big, difficult situation. You have the seniors, people are moving out, both the nurses and doctors, and the younger ones that are supposed to come and fill the vacuum are not really interested. They are not coming. I know in the past 2 years, the recruitment, we always emphasize getting doctors, getting resident doctors to fill in the places. We are so glad that we've gotten vacancies for them, but at the end of it, it's quite challenging getting them to come and, fill in the vacancies. At different occasions, I as a CMAC and even the best CMD has to call people personally to plead with them, come and join, and they will refuse. They say no. And I know We even tried to engage the various HODs of each department. Please try to see how do you get people for your department. And in some departments, at the end of it all, you realize that you don't even have a single person coming. So that presents a very big challenge because the workload is not decreasing. In fact, it keeps on increasing, yet the people on ground, the number is so small to cope with the work. So that presents a big challenge, and you always have this problem. But then I want to say that as management, we have a role to play, as highlighted by Prof. UNUSA, and I think is well noted. We have been doing our best. We continue to do things that will motivate the staff and will also create conducive environment. The ARD leadership, we have been interacting with them, and please, any area they think will help the residents, and if they are suffering, they should come forward. We will discuss and we'll try as much as possible to do the needful. But I must say also, we should also realize this issue of burnout, we all have a role to play. We should be intentional in trying to create measures that will mitigate the problem on us. And let me give example. Prof. UNUSA mentioned that the most vulnerable people, the house officers, the registrars, and that is quite obvious. Even in my department, I always talk about it. And we should look at how do we help the most vulnerable people. At times you are on call, you see that you have only one registrar on call. Maybe in the farm you have 4 SRs. Yes, we know there is hierarchy, but I think it's always better. We are all brothers. We shouldn't say this is for the registrar. The SR should come and help the registrar.
So it's like those of us working in A&E, and then of course lack of support from the seniors. Like for instance, some of our consultants may not be mindful of what the residents are going through. So of course we need to support these younger ones. There is really need for us to be doing that, so that at least we can prevent them from having breakdown. Yes, because by the time we didn't support them, they are likely to develop so many mental health challenges. And of course, according to the presenter, we really need to look at this issue individually and of course at organizational level. Individually, we need to find ways, to try to improve our work-life balance, try to be doing exercise, try to look at our diet and so many other things. And then we should also having some time to have some rest. Otherwise, by the time the work is too much on you, you are likely going to break down. And then, of course, at the organizational level, talking of people like me, there is really need for us to be also trying to see that we have reduced this kind of burden by employing more people to handle so many jobs. And then by also having a kind of work-friendly environment, having some recreational centers in the hospital, and then try to devise certain things that may also help our workers. And at the same time, try to have maybe a certain unit in the hospital that whenever any of the health worker is having certain problems, he can be able to reach out those kind of people. And for us as workers, co-workers, by the time we observe one of us is having some kind of problems, it's not for us to be mocking him or to be saying that he has mental health challenge. No, it's for us to assist him, encourage him to go and see a mental health professional so that at least he can get the assistance that he's supposed to get, so that at least he cannot break down. So by so doing, we can be able to help ourselves. That is it. Most especially in this area whereby we consider we have limited manpower, and then so many of us were even running away from the country, doing Jaffa and so many other things. So I think this lecture is very timely. Thank you very much, Professor Yunusa, for giving us this very topic. And then thank you, RD, for finding this topic worthy of consideration, because it's really a very important topic. And like I told you, most of us used to forget about ourselves. So we are the watchmen. Let's also try to look at our physical and mental health so that we won't end up, having so many problems, and eventually we also become victims. That is it. And I also want to use this opportunity to extend my gratitude to NAT President, though he was represented here, for an award of excellence that he has given me recently. I thank you so much. And of course, I'm a very much advocate of resident doctors for long, because during our residency time, we suffered a lot. And we don't want residents to also suffer like the way we suffered. That is why we really need to support them, do give them the best so that they can be better doctors and even be better than the way we are. Thank you so much for inviting me and for making me to serve as a guest of honor in this lecture. And I thank each and everyone that is here for attending this all-important lecture. Thank you so much. And I wish you all the best. Thank you very much. Yeah. Mm.
Thank you very much for those insightful comments. We're really grateful, sir. So we'll draw the curtains of comments with the comment of our indefatigable leader, our strategic militant leader, Dr. Muhammad Suleiman, heavily represented by the Publicity and Social Secretary of NAD, Dr. Abdulmajid Yahya. Dr. Abdulmajid Yahya, sir.
So sorry, my network has been very, very poor. I don't know if I'm audible.
You are audible, sir.
All right, thank you very much. Good evening. I collapse. Hello, I don't know if I'm audible.
You're audible, sir.
Hello? Okay,
Yes, sir,
okay,
you're
thank
audible.
you. And it took me more than a year to recover. Okay, it took me more than a year to recover. I had 3 admissions. Even one of the admissions, I spent 20 days in ICU. So these are some of the things that we always fight. In fact, I couldn't go for exams. So these are a few of the things that can actually happen to our members because of excess workload. And then I'm happy that we have 2 of our CMDs here. So I would like to make a passionate appeal. I'm happy